everyone. Hope everyone's doing well. Today we're going to be doing our Funding for Telehealth webinar. So, a little bit about Generation West Virginia. It was founded in 2007, and Generation West Virginia is a statewide nonprofit that ensures young West Virginians have the skills and opportunities to access well-paying careers in the Mountain State so they can choose to stay. And we have four different sectors of it. We have the Career Connector, our fellowship, New Force, and broadband. So I'm going to hand it over to our broadband director, Annie, to talk a little bit more about the broadband part of it.
Okay. All right. So if you go to the next slide, please. All right, so just a little bit about the GWV broadband program. We started out doing mainly infrastructure work, and over the last couple years, we've really switched over to focusing on all of the topics on digital access and adoption or digital inclusion. We've done community planning, a lot of technical assistance, and this is kind of how we ended up in working with these folks through telehealth. We're really excited to have them on, but that whole side of our work really focuses in on identifying some of the other barriers and some of the areas of need within the state related to digital access. It's not just the infrastructure, it's also, the skills, the knowledge, the right tools that folks need to be able to effectively use these really exciting new opportunities. So we'll hear more about that later. I did want to just plug that we also this year are launching our first West Virginia Connected Communities Network. The first meeting is actually tomorrow, February 24th at 3 p.m. I have a registration link I'll drop in the chat in case anyone wants to join us. We'd love to have you. This is basically an outgrowth of our existing. We've had 18 community steering committees. And this is a way to kind of continue the conversation on a statewide level as we all work to figure out different strategies for how to address these key gaps across the state. All right, so Emma, I'm gonna hand it back over to you, I think.
So, just a quick introduction for myself. I'm Emma. I'm with American Connection Corps, serving through Generation West Virginia. And our webinar today is going to be focused on telehealth funding in West Virginia. Some key topics be community access, funding sources for telehealth, and how funding is sustainable. And our two main speakers today are Christian and Jen. Christian is with the CEO of Ingenium Digital Health Advisors, and then Jen is the Essential Project Management. And then there's a few other speakers too. So I'm going to hand it over to them now. So I'm going to stop sharing my slides, and Christian, you can share yours.
Sounds very good. All right. I think we're in business. Let me just make some rearrangements. Thanks for inviting us to share what we have learned in the last years or last decades about telehealth and telehealth funding. We've been working with Generation West Virginia for the last 6 months here through Annie, helping with some organizations in West Virginia to put together a plan for what they could be doing with funding if and when it becomes available in order to build out their telehealth services. And so we're happy to talk about this. We have a full team here that we are introducing. And I put some questions in the chat here because we really would like to tailor it even as we speak live here to your audience. So again, feel free to post any questions along the way here in the chat, and we'll keep an eye on it. And we have a Q&A kind of 5 minutes before we're closing out with another set of slides. But so we'll have a time there as well. But very, very great to be invited. So yeah, what type of organization do you represent? And then we have kind of the four of us as speakers. We probably could spend 10 minutes introducing ourselves, but I'll spare you that. So my name is Christian Laster. I'm the founder and CEO of Ingenium Digital Health Advisors. Like Emma said, I've been in telehealth for 15 years, started in healthcare at the Mayo Clinic, and my accent, I'll tell you later where that's from if you can figure it out on your own. Jen.
Sure. Jen Donathan, I'm based out of Cleveland, Ohio, and I'm with Essential Project Management. I have been in the healthcare space for about a decade, really focused on project management, quality improvement, but over the last several years have been involved in more of telehealth and those ventures. So wonderful to meet you all. I can hand it over to Sherry.
Hi, I'm Sherry Snyder. I'm in the Cleveland area along with Jen. Um, I have a plethora of experience over the last 30 years, including marketing, public relations, organizational psychology, and higher education administration. But in this particular case, I'm coming in with the lens of community readiness and how to implement change in that space. Ryan?
Good afternoon, everyone. My name is Ryan Baker. My day job, I am the administrator for the North Carolina statewide telepsychiatry program, which is a state funded telepsych program that literally runs from the mountains to the coast. We cover roughly about 50 locations across the state of North Carolina. And in this role, I am a partner with Jen and Sherry in Essential Project Management. Happy to be here.
Great. Thank you very much. Okay, off we go here. Always like to start with some definitions. After way too many committee meetings at the Mayo Clinic, I learned that everybody agreed until somebody defined it. And so that's kind of essential. And so telehealth, I've for the longest time defined as delivering care at a distance, simple and pure, right? It's not about technology, really. It's about delivering care. That's the ultimate outcome. And there's various different technology modalities that we can use, which we'll dive in the next few slides here. And then telemedicine, that's a term that's really going out of fashion. So I think I need to update this slide, is practicing medicine at a distance. The difference here is that telemedicine is the interactions between clinicians and patients. Telehealth really encompasses everything, scheduling your appointment, downloading lab results, logging into the patient portal, right? So telehealth is really the whole world of care delivery, whereas practicing medicine is the specific interactions. So, but telehealth, virtual health, connected care, telecare, everything is possible now. But I did build out this taxonomy years back where telehealth is the overarching term, telemedicine, the subset, alongside with teleeducation or patient portals. And then there's interactive patient care. And then the one that people most equate to telehealth is video visits, right? So most people say telehealth, that's a video visit, but it also involves remote patient or remote physiological monitoring as well as store and forward. So taking a picture of your lesion or of your mole, sending it to a dermatologist, that is store and forward telemedicine, or rural clinician faxing an EKG to a cardiologist, that is telehealth as well. So it's really when the two people that are interacting with each other are not in the same room or are interacting asynchronously. So that brings up a whole world here. Here's just a subset of 9 different ways of how you can do telehealth. So at the center here, the most synchronous one and kind of medium complexity is audio and video televisits. Telephonic care, which is what mostly was practiced during COVID because video did not really work, and is also telehealth. Remote audio video tele exams, where you have an exam tool that's more complex. Then we have the world of RPM. Secure messaging will become more and more in favor because, again, as a society, we have moved to communicating with our loved ones and friends and family, and even with other support staff with secure messaging. Healthcare still lags a little bit behind, trying to figure out who's actually going to answer all those messages. That's one of the challenges. But AI to the rescue. Now AI will answer 80% of our text, which maybe is a good thing. So, but that's not our topic. So, and then store and forward, and then digital therapeutics, right? Sending patients home with some devices and really looking at your there. So that's the most complex, most asynchronous one. So that's just give you a roadmap here, just expand kind of your thinking and understanding of telehealth. So next, Emma did a wonderful job of giving us a nice structured hierarchical agenda of all the topics she thought would be of interest. So that was very, very good that we didn't have to do that brainstorm. We could just lean right into the structure. And so the first thing that Emma wanted us to talk about is what are the patient's barriers here to telehealth? And in a nutshell, that's access, digital literacy, and engagement. Everyone thinks about access and digital literacy. Not many people think about engagement, but I think that is actually the most important one. And it actually does not just apply to rural as well. It's just an overall in general, when you're trying to engage with people at a distance, it is much harder than when they're in the clinic, but they can only be in the clinic so often. So that's the challenge. Access, obviously, you know that, and you're living it in West Virginia. The distance, right, very little or no public transportation, maybe no gas money. Also, the distance to specialty care providers, right? That becomes a real challenge, not just the local primary care or behavioral health services, but also specialty care services. Then the time that it requires, right? If you're working multiple jobs, if you have need to arrange for daycare, that makes it hard. And then the technology. Not only that you may have a smartphone, you may have a computer, but broadband connectivity is hard to come by. Again, we're talking about broadband here, and looking at a build out here, or leveraging kind of for wireless internet, so 5G internet or satellite based internet as well. So that's the access layers, and then the solutions here is could be potentially public telehealth access points where people can stop by in their town, so they don't have to drive 25 minutes or even 2 hours, but they can drive 5, 7 minutes into town, or even walk. Could be in libraries, community centers. And then there could be some intermittent clinics that could be opened up that only open 2, 3 times a week, where somebody in MA lets them in, takes your blood pressure, but then sits you down in front of a screen to see your primary care or specialty care provider. And then obviously mobile clinics, which are going around. There's mobile vans. There's people who are setting up tents within the communities. And I'm just mentioned Dollar General because Dollar General seemingly has kind of shifted a little bit in allowing people to park in the parking lots, to set up the clinic in the parking lot. So that's kind of one community partnership, which we'll also talk about here. And then, yeah, libraries. So there's a picture of a library in Delaware, and that's a booth that you see. It's a standalone sound insulated booth with a sliding door where you can go in and you can reserve this booth, and then you can have a private conversation in the library. Somebody may even be able to help you up a little bit on how to get to your appointment. And so that's a way what that actually would look like in reality when we go and establish telehealth access points within the community. Here's another resource. And again, we'll send out these slides to you, Emma, and then you can distribute them to the people that signed up for the webinar or that are on your mailing list, and we'll have all the links there. But this is an effort by the Northwest Regional Telehealth Resource Center out of Utah to kind of map nationwide the telehealth access points that are available. And I just zoomed in here on West Virginia and the surrounding. As you can see, nobody has reported that there's a telehealth access point. So there may very well be some, although we have not heard about any. Although actually, Jen and her team came across one in a school that is publicly accessible by a health system. And so, right, so there's some. But you can see this is an effort that is underway, and we'll talk about telehealth access points a few more times here, because it's one way to just provide that infrastructure to the residents in the area. And then over here in Delaware, you see all the libraries, right? They had a grant and they installed it in 8, 9, 10 libraries. And so that's where those access points are coming from. Second one is digital literacy. A lot of people are not digital natives, as we like to call them these days. Even and the EHR vendors oftentimes require that you have an email account to even set up anything. And most people haven't really opened an email account, or don't have an email account, or don't check it because they use texting, they use WhatsApp, they use Facebook Messenger, as I mentioned earlier, right? So it's a little bit they don't work like I'm on email all day long, but most people are not. And so, right, creating, accessing a patient portal account, installing apps even on your smartphone, troubleshooting sound video problems, right? Those are some of the digital literacy challenges that we encounter. And so the solutions here is, if we have a telehealth access point, then we can provide support. Some grant programs have established community digital navigators that are going into the community and that are helping people. Could be through the clinics, could be through an FQHC, could be through other community organizations. There's also community health workers that increasingly are getting trained in helping people to overcome digital literacy challenges. Community paramedics could also help you maybe set up your home monitoring equipment, things of that nature. So again, there's partnership opportunities here with the people that are already out in the community, meeting with the patients where they are. In-clinic assistance after an in-person visit. Here, let me help you get on the portal. Let me help you set up this app. Let's make a little test call, right? And then also concept that we're promoting is telehealth tech checks to actually have a test visit a few days before a patient has their first telehealth visit, just to make sure that everything is working well. And if it doesn't, then we can still bring them in person and shift it to an in-person visit. So those are some of the solutions. Telehealth check. This is basically just a script where some staff with good interpersonal skills and technical affinity, as we put it in the right-hand corner, goes in and meets with the patient and says, well, where are you going to be located when you're meeting with Dr. Strout next Tuesday? And then what technology will you be using and how are you connected? And then here's how you join. You click on this link and then, oh, your audio and video is working, your camera angle. Maybe you should prop it up on the table and not put it on the table so we see the ceiling, or don't hold it in your hand. It's too shaky. Watch your background, what people can see in your background, and also is your lighting good, right? So just it's a quick script to go through to make sure that the patient and the physician and the clinician have a great first experience. So that's just one intervention. And then the last topic, engagement. And again, that's not limited to telehealth. I think that's the whole, that's actually the holy grail of chronic care management across the board, and especially for rural groups here is for rural patients and rural residents. Right, it's making sure that patients keep appointments and that they maybe proactively cancel, or we have all these text messages, automated voicemails or voice messages or text messages we receive reminding us that our dental cleaning that we scheduled 9 months ago is finally coming up, so which is actually a good thing. Participation in the care plan, right? Fill and take the medications, complete the tests, and also that they're communicating with us. And so that's really, really key. And telehealth can overcome that barrier of provide regular contacts. So again, telehealth can make it easier because you don't have that logistical overhead. You can actually initiate. We've helped some of our clients to convert cancellations and no-shows to telehealth, right? If somebody says, yeah, I'm sorry, I can't come in tomorrow, I say, well, would telehealth work? So, well, I've never tried that. Well, we can try it right now, right? So don't let them get off the hook unless they're afraid of the doctor because they're going to get a flu shot. Then maybe we can still have them come. Yeah, get them participating in the care plan. Maybe have a medication reconciliation with a pharmacist, right? You get discharged from a hospital, you end up with 4 more bottles with 3 more pills that all have the same color and similar shape, and you're like, how this is going to work? And so helping them, enrolling them in remote patient monitoring to increase engagement, and then again having some interactions. Also, if you have dual language speaking or foreign language speaking patients, right, having a real-time video interpretation service is another way to engage people. And then other AI solutions are up and coming that actually, after you had the visit with your clinician, then you can actually go back and you talk to an avatar of that clinician to break it down to you and what the conversation was about. I mean, the technology is already there. When we get to see it as a matter of payment and other political barriers. So anyway, so those were the things of the barriers. And with that, I hand it over to Jen. And what we're going to be doing for this presentation is we're going to go back and forth here. So there's a set of slides that Jen and her team are going to talk about, and then I'll chime in. And again, we're looking at also monitoring the chat if you have any questions that you want us to make sure we address.
Absolutely. Thank you. So now we're going to look at the common community needs. So when we talk about telehealth access, we've obviously focused on the technology piece, but we also have seen that access is really about systems trust and readiness, not strictly the broadband, but of course that is important. So the first one is broadband and device access. It sounds pretty straightforward, but rarely is. Communities may technically have internet coverage, but reliability, speed, and affordability are often inconsistent, especially for video visits. So we also see reliance on physical access points like clinics, health departments, and sometimes libraries. These can be valuable, but they come with caveats, especially around privacy, staffing, and policy constraints. A common barrier we encounter is what we call the liability trap. So communities often get stuck asking, who supervises the visit, who is CPR trained, who owns the risk if something goes wrong. Without clear answers, equipment often ends up literally sitting in a corner unused. So really trying to address those common questions at the beginning is really important. Second, again, private appropriate spaces for visits. So again, a device alone isn't enough if there is nowhere safe or confidential for a patient to use it. Communities need clarity around who's responsible during the visit, especially for pediatric behavioral health or high-risk encounters. This includes supervision, emergency response, and workflow integration. When these roles aren't clearly defined at the outset, telehealth becomes an extra instead of part of the normal operation. And that's another reason why adoption can stall. And then, as mentioned before, digital literacy and community readiness. So along with the technical literacy, there's also general comfort and readiness that needs to be considered of the population. So digital literacy, you want to look at trust, the readiness, the confidence of the folks using it and deploying it. Do residents feel safe when using telehealth? Do they trust it? Is there fear, skepticism, or any kind of cultural resistance? And does telehealth fit in the way care is typically accessed in that community? This is where community readiness comes in. Readiness is not the same as infrastructure, though that is important. You can have broadband and devices, but without addressing the trust, the cultural appropriateness, and confidence of the community you're trying to implement it in, telehealth simply won't succeed. So when we assess telehealth access, we also want to consider and emphasize that telehealth is a process change as well, not just the technology deployment. Communities need support across the infrastructure, workflow, and readiness. Otherwise, well-intentioned investments don't translate into real use. Let me go to the next slide.
Sure. Yep. All right, we'll get to funding sources. So one way to look at it is how much of the funding actually goes to what, right? And so as Jen just mentioned, right, it's technology and equipment. But then there's also, there may be some remodeling, like if in library you want to set up a room or a community health center. So, but then a bunch of the money actually should go to, and oftentimes does not go to because the funding is restricted to technology, to that technical assistance. And that's really about creating that cultural readiness, that community readiness. And it's all about change management, about winning the hearts and the minds of the clinicians and staff and patients and everybody involved, and making it easy, right? Designing the workflows and training them. And so I think we've learned over the years that funding and ideally should not be used to cover staff cost and clinician cost. It really should be designed to be financially sustainable. But again, it should fund that startup cost. So a successful telehealth service really has three elements. How is this strategically important to your community, to your organization, to your clinic, to your patients, right? And then what's the business case? What is the financial reimbursement for the telehealth services? These days, we'll get into that a little bit more later. Most telehealth is reimbursed. And it can be made so that you don't have to have ongoing operational support for or operational funding. And then the third one, very important, is the clinical case. And that's at the intersection of a great clinical case and a great financial case and a great strategic case is where the most successful telehealth services live. And so it's really, as I always like to say, when you look at a health system, if the CEO for the strategic case and the CFO for the business case and the CMO are all happy and agree, then we know we have a good telehealth service that we can launch here. So with that, there are some funding sources that we can siphon off of. So Jen, back to you or your team.
Sure. Go on, Ryan.
Hey, right. Funding sources, as you all know, that's we've got to have the money to start these programs. So there's really three buckets of funding that I'm sure all of you at somewhere in your career have been involved in one or two or possibly all three of these. Of course, you have the federal funding, which is very competitive. You also know if you've got any federal funding, the reporting and the metrics and the scrutiny are very intense with these funds, and it's actually it was already at a high level, has ratcheted up in the last couple of years as well. And I know with the rural health transformation funds coming, there's going to be an additional level of scrutiny when it comes to these federal funds with that as well. So you really have to stay on top of those things and with the federal funding. Best suited for multi-partner long-term initiatives. A lot of federal funds that we've seen that I've worked with is a multi-partner, whether within your own organization or with several external organizations working together to meet a common goal. State and local funding, that go back to the federal process. Usually that is a very long process. Now, Christian can talk more about this with the rural health transformation. It's going to be the opposite of what we're used to. It seems like it's going to be a very expedited for that particular fund. But traditionally, federal funding has been slow. And then even when you are awarded the money, the contract process can take months, if not years. The longest one I had is it took 3 years to get a contract in place for some federal funding that we received. So luckily, we did not have all our eggs in that one basket. State and local funding, more accessible and faster deploy, aligns with your regional. These are usually grants or within your DHHS or some kind of organizations within your state, like Generation West Virginia, who have an understanding of what's going on the ground. Very, very good for pilots. So are some of the federal funding as well. Some of that federal fundings in the past have been good for pilots, but I tend to like more local state funding as a pilot project because you see have flexibility. They still have reporting needs, but the scrutiny, at least in the states that I've dealt with, has not been as cumbersome as federal funding. You tend to have more flexibility. And then the foundations of private funders. These are the ones where you tend to have the most flexibility. It is relationship built, in my experience. It's having those relationships. It's usually because you've got one of the other two funding sources that you've shown what the project you're working on, and maybe you needed some little bit more funding to help out with sustainability or growth. The foundations of private funders, outcomes, equity, and community impact, strong value. I cannot emphasize this enough. Storytelling and lived experiences. And in my experience, and probably many of yours, when you are successful with a foundation and they find your project to be, once you've completed, that you've done a great job, you're more than likely to be able to go back to them in the future for additional projects as well. Next slide. Common reasons. And Jen, you stop me when it's my other computer screen's down, so you stop me when it's time for somebody else to take it on. Okay.
You're good.
All right. Common reasons telehealth grants fail. Staffing and operations under budgeted. Going back to what Christian said, you should, my opinion, and I think Christian agrees, we should never be counting on grants or funding, external funding, to fully cover the expense of your staffing and operations. You've got to have some skin in the game with that. You've got to have the money for the training and the ongoing, but also once that funding ends, what's going to happen if you haven't invested some of your own resources or gone and done a joint federal, state, and then got maybe some private funds to help out with that. When it happens, I've seen the ones that have failed is one or two people on the program for telehealth, and they just burn out, or worse, they leave and no one else knows about what's going on. You're just setting yourself up to fail in that. Sustainability plans lack clarity, long-term funding strategy. You've got to go into it before you can apply for a grant. I believe how you're going to make this work post funding, when the grant runs out. How is this going to make work? How are we going to make this work in the long run? How am I going to adjust the existing workflows? I tell everyone that we work with is we got to keep it between the ditches, as we say down here down south. You've got two ditches here on each side of the road, and you've got to be flexible. There's a lot of flexibility in there between, but there are some guardrails. We've got to keep everything in between, and most of the time those are clinical reasons or grant related reasons. But you've got to be flexible to be able to adjust as you're going on with the telehealth and getting the program up and going. Focus placement placed on equipment instead of people. This is the one that, going back to what Jen says, where I go to places and I see they've got this brand new equipment and it's been sitting in the corner for years now and never used. Getting money for equipment, in my experience, is the easy part. It's having your priorities, your technology, your training, your planning. That's the easy part, is getting the equipment. But how are you going to deploy that equipment? Who's going to be in charge of what? Who's going to do what? I see a lot of people that get the equipment, then they go, then what? That should be the first question you ask before applying for a grant when you're going to that, not just getting the equipment in place.
I want to add to that, Ryan, right, and bring that point home one more time, is that most organizations are good at running things. I mean, that's why you're in business, healthcare organizations, community organizations, but especially healthcare organizations are good at running things. Some of the better ones are good at optimizing things. They look at the performance and then they optimize it. But to launch a new service, to establish something completely new, smaller rural healthcare organizations really don't have that in their DNA. They don't have the staff. They don't have like what Jen has, right? She called essential PM, essential project manager. They don't have essential project managers, right? And I mean, the first thing I've been through project management training, the first thing we learned in project management school is that project is very different from operations, right? A project is a unique, a one-time undertaking to achieve a certain specific outcome, right? That's the goal. And so this is also when you're launching a new service with the funding, right? It's leveraging the talent of people who have done this before, who are experienced in launching things versus running things is very key and very critical to the long-term success. Because otherwise, I love that gear gathers dust syndrome there.
Yeah, that's right, Chris. If you don't have that, you're not set up for long-term success. You're setting yourself up for failure. I'm not saying that some people won't, but it just becomes another task on the task list for the people that are inside the organization.
Yeah, exactly. Good. Okay, we're getting into the nitty-gritty detail here. Again, we'll share these slides for you, so I'm not going to read you every bullet point, but overall, the good news is that post-COVID here, we really have telehealth coverage across the board, Medicare and Medicaid, cover most video visits, and also most states are covering RPM. Not all of them. Commercial insurers are also reimbursing telehealth. Policies vary by state and by plan, and then some states have actually the dark blue states you see on the right side. Those are the states that have mandated that there's payment parity for telehealth visits, and so that is actually good news. And primary care, behavioral health, chronic care management, specialty care. There's a whole plethora of services that do qualify for it. Again, there's lots of good resources out there, like the one in the right-hand corner there. The Center for Connected Health Policy, which has it broken down by every state. So on the national level for Medicare, and then on the West Virginia level for Medicaid, as well as any state regulations. So you can always look there. And then, just like any healthcare billing, you need to have accurate documentation. And all you do these days is now you apply a location code for most telehealth billing. Gotten greatly simplified in 2020 and 2021. It was a mess. There were the location codes basis. But we've settled here finally on that. And then most states also require some form of patient consent, at least a one-time consent. And so that's just the basic thing. So the good news is, yes. Now, Congress keeps kicking the can down the road. They keep extending any exemptions, and I'm not even paying attention anymore because I'm an optimist, hoping that it will be extended. And someday some bill it'll be made permanent, or maybe it's already permanent now. I've just lost track because it's just such a boring game. Ryan touched on this here, and Jen as well. Partnerships are really key, right? It takes a village to pull this off and really to bring telehealth into a community to provide better access to care. It's not just about the funding, but it's you got to align with a community partner. So school districts, library systems, community centers. Some states have grants that have formed tech alliances, just general tech alliances, kind of, I think, what Generation West Virginia is pursuing, but then also healthcare specific tech alliances, volunteer fire stations, other not-for-profits. Anybody who has an interest in improving the health and well-being of the residents can be an ally, can be a partner. And then obviously on the clinical side, right, the regional health system for the specialty care services or specialty care providers, maybe virtual only care providers, right, that provide just like virtual cardiology or even virtual behavioral health. And then you have then also the more on the ground partners in EMS services, home care providers, community health workers. So really look at build a coalition, build a partnership in order to kind of go jointly after that funding and really demonstrate to the decision makers that you have really aligned the values of the different community partners to that. So good. So there was a few more. RPM stands for remote patient monitoring or remote physiological monitoring. Thank you, Annie. Yes, okay, and somebody already. Okay, yeah. It's you send a patient home with blood pressure scale, maybe glucometer, and then they periodically, at daily basis, take these measurements. They get automatically transmitted into the cloud, and then there's an interface where a monitoring technician sits and reviews which patient has submitted their data, and then they also look at whether the data, the vital signs, are within the range. And it's a great way to keep touch with the patients between visits and make sure that they don't deteriorate. Maybe they don't like the medication because of the side effect. Well, then we need a new medication, but they don't tell us. And so yeah, so that's RPM. What comes first, the proper connectivity or the telehealth partnerships alliance? Chicken or the egg? Um, Ryan, I have an opinion. I'll let you or anybody else go first. Or Sherry. Sherry's raising her hand there. Okay,
There
let
you
you.
go
No,
first.
I was just confirming that, I have an opinion as well. But I think it's also the lens by which we look through in our specialty. My lens would look at, is the community ready to take this on? Is the organization prepared to take this on? Do we have the right people at the table to ensure that we have people in the room who can support this program if we are not there? So that's my lens. So it really is the internal healthcare system. Are they ready? And is the community ready to take this on? So that's my perspective. But I think Ryan might have a different perspective from the internal portion that relates to the hospital.
Yeah, yeah, and I'm not just this hospital, any healthcare is this is common, Sarah. What I'm about to tell you is you get one or two people inside of a healthcare organization that are gun-ho for wanting to do telehealth, but they haven't had that discussion internally with the entire team. When I say the entire team, I'm talking about everybody. Here's a common occurrence. The one or two people reach out to us, say, hey, we want to do telepsychiatry with your organization. And then we set up this big meeting and go in, travel across the state, go there, and nobody else except the two people that we were talking with know what's going on. It's got to start internally with the ask internally with the entire organization, or at least the leaders within the organization. And when I say leaders, not just C-suite, the floor leaders and the nursing leaders and things like that is, hey, is this something as an organization that we're going to look at doing? One thing I see, the big divide I see right now, and this is just what I see, is the younger generation is it seems to be more accepting of this, whereas some of the older clinicians are kind of against it. But what I see is once you start having the conversation and explaining how it works, the light bulb goes off. Oh, okay. And not that COVID was a positive in any form, but one of the things that COVID did was force people to embrace technology, which has made people more comfortable. But yes, what Sherry said, I believe it is 100% correct. But then internally, that is where I see you've got to make sure it's something that you as an organization want to embrace and move forward. Because I tell everybody this, it takes the same amount of work, whether you set up telehealth and see one patient or you set up telehealth and see thousands of patients. The setup is all the same. So it's an investment of time, resources, and energy that goes into that.
Yeah,
Thank you.
few comments on that. Thank you for the question, Sarah. Definitely good. I think for me, it's clear cut. The partnership and the alliance and the vision comes first. We can never wait until the perfect alignment of the infrastructure being there. I love these five powerful words. What can we do now? What can we do? If you get some funding to hand out satellite hotspots, maybe that's an opportunity, right? If you can find another partner to set up a 5G Wi-Fi beam for a region, even though that's not really broadband fiber, right? You can do that. If you have a strong case, and if you're already 1.5 years into building a community alliance, and then you apply for funding, right? You're going to be a darling of the reviewers because you have a success story, you have already invested. You're not just waiting around. So for me, it's not a chicken or the egg problem. And then to Ryan's point, clinician resistance is real, and it is somewhat generational. But it's very easy to overcome. Our chief clinical officer does a 30-minute virtual exam training, taking a primary care physician through the process on how to conduct an exam virtually with no exam tools whatsoever over video, and how to properly document an EHR. And after that, the primary care providers are changed clinicians because finally somebody actually told them how it could be done. And during COVID, a lot of video did not work, was traumatic. So I'm always testing for post-traumatic stress disorder when I talk to any clinician that have experience. And so, yeah, so definitely very good.
And Christian, let me piggyback off that. Sarah,
Yes.
what Christian just said, it's not necessarily the buy-in, it's just that they're involved in the conversation when it first happens. They just
Yes.
want to be involved in the conversation.
Yeah.
That Christian is exactly right. That's all they want to do is just be involved.
Good. I think I'll hand the microphone back to you then, Ryan. I think with the three examples here, there.
Yeah, and so this is my home program here, North Carolina, the North Carolina Statewide Telepsychiatry Service. I'm going to give you a brief little overview. We had a crisis back in 2009. They shut down in North Carolina, the mental health reform shut down a lot of the mental health services that people were getting. So guess what happened? They all started showing up at the emergency department. Long story short, my university, East Carolina University, along with UNC Chapel Hill and Wake Forest and other, came up with this idea of providing telepsychiatry services remotely because there's not enough psychiatrists then and now to provide services in all the rural hospitals. So we come in virtually and provide telepsychiatry consults, started in hospitals, and now we have formed out to rural clinics, mostly primary care clinics and health departments and rural health clinics, and also working on some FQHCs as well. It's a hub and spoke model. It's where the provider is centrally based across the state, and they work with the continuity of care. It's not a different provider working with every primary care physician. It's the same psychiatrist working with the same clinics. So the ED model is what we call a firehouse model. So we're responding to a need. So someone comes into the ED, and I won't go into it. A referral comes to us, and then we see the patient. It goes into a queue. We see the kid. We're like McDonald's, first come, first serve in the drive-through. On the community side part, in the community clinics, it is a scheduled clinic setting where the actual patient goes into their primary care clinic. So you're eliminating the worry of your car being seen outside a psychiatry office. That might not sound like a big deal, but it is a huge deal in the mental health world where people don't want to be labeled as having mental health problems. They come into that clinic, they are checked in, sit in an office, and my psychiatrist virtually sees them and then makes medication recommendations to their primary care physician, who then writes those orders and gets the script in that patient's hand. So we've knocked that out all at one time. And why do we do that? Because we know that primary care physicians and community-based providers treat more mental health than most psychiatrists in this country do. They are the ones that are seeing the most patients with anxiety, depression, and on the mild side of things. So, Jen?
Yep. Absolutely. So next example are state-based programs called Pediatric Mental Health Care Access Programs. So these are federally funded entities, but they are located state by state and across all 50 states and territories. And so each program is tackling this a little bit differently, but they're all seeking to provide teleconsultative services to their states, to providers in their state. They could be primary care based, they could be school based, they could be in the emergency department. These are just 4 teams that we've worked with. Michigan has focused on highlighting its rapid consult model combined with strong provider education. Maryland's team has focused on emphasizing integration between academic centers and community providers. Virginia's team has used statewide coordination while still allowing regional flexibility in their teleconsultative services. California is operating multiple hubs to address scale, geography, population diversity. Across all of these, the structure is adapted to local context, but the core concept for all of these programs is the same. It's having specialist support delivered virtually. And again, they're focused mainly on mental and behavioral health services, delivering it virtually where and when providers need it. So if they need guidance or recommendations on how to handle a presenting patient with mental and behavioral health, they can contact their state's PMHCA program to get resources. And then school-based, so this is local to you all. We'd worked with a team in Hamlin. This is another powerful example. where telehealth is being implemented directly in school-based health centers. So what makes this model great is that school nurses are the backbone of this. They're trusted entities in the community. They understand the families that they're serving, and they already serve as a first point of contact in their community. And so this school-based health workflow has already existed. They're adding the telehealth component on top of it to expand their reach. So instead of asking families to navigate new systems or travel long distances, care is being brought into a familiar setting with a known and trusted professional supporting the visit. And so, yeah, our team worked directly with this community, and it's a great example of how telehealth can succeed when it's designed around existing relationships. So the technology is an added bonus.
Briefly, Jen and Ryan, could you talk about how these three programs were funded?
Yeah, I will talk about the North Carolina first. The initial funding for this for North Carolina came from two entities. It came from the Duke Endowment, which was a private foundation that, like I mentioned earlier, and also from the state of North Carolina, the North Carolina General Assembly. So what happened is in North Carolina, the North Carolina Hospital Association, with the crisis that was going on in the emergency department, went to the legislature and said, "Hey, y'all got to do something." Out of that, this NC STEP spun, but the legislature actually put money where their mouths were, and for 3 years funded part of this. And then after 3 years, they actually codified it, and now we are in the state statutes permanently of getting reoccurring funding of $1.82 million a year. The Duke Endowment Fund was for 5 years and really helped us get our footing and our base to back in the day, and some of us older when we remember, it wasn't always a Logitech camera or just a small camera. We used to call them big Berthas, these big carts. They cost 25 grand a piece. And then we won't talk about T1 lines and everything else that used to see, Christian knows what I'm talking about. That was a heavy expense starting up. Now my biggest expense with the projects that I do are my manpower and my people. But back then, your technology was the biggest lift. And from that, we've had additional federal and additional state grants and others as we've done special projects along the way, such as at universities, pediatric projects, and things like that. And Jen or Sherry, I'll let you take the pediatric mental health.
Yeah, absolutely. So the PMHCs, they are federally funded through HRSA, or the Health Resources and Service Administration. That's been their primary funding, though a lot of these teams, because it's a year-by-year grant application, a lot of them are encouraged to find other means of funding for long-term sustainability. So some have partnered with academic institutions in their state to help fund their staff. Others have looked at other private foundations to fund their operations. So a lot of them are tackling this differently state by state, but their primary source of funding has been federal. And then, go ahead, sorry.
Yeah, no, I'm also watching the clock here. I know this meeting was scheduled 1.5 hours, at least on our calendars, but I'm assuming that some people may have to drop off. Again, you'll get an email from us here. But how's the funding being used? Again, pretty straightforward now, right? Equipment's in space, staffing, and training. I think that's pretty, and then workflow, right? And that's really the heavy lift, is designing and the training and optimizing and actually rolling it out and engaging the community and raising the awareness. And so these are the four different funding buckets. I want to point out on that because, again, community access points always sound exciting, but they're very hard to actually get off the ground and get utilization out of. They sound good in theory, but in practice, they fall apart. So I've been doing some more thinking, and I think I finally figured out why. At least that's my theory right now. So there's people who want telehealth, and there's people that don't want telehealth. And then there's people who have a lack of either digital literacy or technology or connectivity or, like for behavioral health, privacy. Maybe they don't want to do the telehealth visit from home, the mental health visit. So but I think I've drawn this circle quite accurately, right? That most people who don't want telehealth are the ones that don't have digital literacy, technology, connectivity, and privacy. And the ones that want telehealth, they have the technology and they have the time and they have the willingness to get this done. And so this sliver that would use a telehealth access point is actually relatively small because the people who want to do telehealth are the ones that have digital literacy and are familiar with technology and have connectivity. So it's not even chicken or the egg problem. It's some kind of other problem. Somebody can figure that out. But the untapped potential is this if we can use if we can help people to overcome their digital literacy concerns or the technology and connectivity concerns, right? We can turn them from I don't want to do telehealth and simply because they are afraid that they don't know what to do and they don't want to be embarrassed. We can help them, and that takes a heavy lift of the community, community education, library education, community health centers, individual outreach by home nurses, by community health workers, by community paramedics that suggest to them. Then when a person of trust suggests to them, hey, would you like to try telehealth rather than going through the hassle of coming in, right? And so therein lies really the opportunity. So that's again what we said. Community partnerships are really, really key because you got to involve everybody who has interactions with this patient to help them to overcome maybe any concerns that they may have. So that's I think is the great opportunity of what's missing. Good. Clinical partnership is key. Clinician referral to the telehealth access points is critical. If your primary care physician says, "Hey, next time, rather than driving in here, did you know that in your library we also have an access point now? You can just go there, right? And here's what you do." Or Mary on the way out can give you some information on that, right? If that referral comes from the clinician, the behavioral clinician, primary care clinician, then that is a really an easy way to get this started. But it takes that effort of the personal referral to do that. So and here's another summary of the challenges they're faced and addressed. Jen?
Yep, and this really summarizes a lot of what we've already reiterated again. So really addressing challenges that we've discussed, again, provider support over platform selection. Consultation models have reduced isolation and built clinical confidence, but we really want that provider buy-in from the get-go. We've seen workflow integration really help drive adoption. So if it can be embedded into existing infrastructure, the uptake and the buy-in will increase. Also having a centralized infrastructure we've seen has reduced workforce strain. So shared specialty resources across rural and underserved regions has been a plus. Having care embedded locally can improve access. So integrating telehealth into primary care, EDs, community settings, it really starts in the community for it to take. And then really establishing those partnerships to enable long-term sustainability. So state agencies, academic centers, rural systems, and finding those partners at the get-go.
Good. All right. Thank you. All right. Ensuring program sustainability. I think we already talked about this, but let's drive the point home one more time.
We can actually, I'm gonna say thank you to everybody. I do have to jump off. Jen, can you take these slides for me?
Absolutely.
But thank you everybody for having us. I greatly appreciate your interest in this, and I hope to catch up with everybody soon.
Thank you, Sherry.
All right. So again, I think we've beaten this pretty hard, but again, you want to make sure you're aligning telehealth with community needs. So when we talk about aligning it with community needs, the key concept is assessing that readiness. It isn't just about the technology rollout; it's a process change. So communities have to be ready to use it, trust it, and have to see value in it. And community also goes to the provider team or the team that is going to actually do the implementation. So that means asking important questions up front. Are residents ready to trust the telehealth? Is there fear, skepticism, resistance? Are we approaching this in a culturally appropriate way for that community? And then also having the broadband and devices is also important as well. So you want to consider your infrastructure. So readiness includes infrastructure, but it goes well beyond that. And so looking at, budgeting for ongoing costs. So a common challenge we see is you underestimate the true cost of telehealth. Technology is usually easiest and most predictable expense, but you want to consider the ongoing costs. Those are the people who are implementing the strategy. So staffing includes coordination, training, troubleshooting, coverage, reporting, et cetera. So not just the clinical time. So you want to think about the sustainability up front before launch, not after. And so you want to clearly define those roles up front, who's owning what's funded, what's the training look like, et cetera. So you want to consider hidden costs like onboarding, reporting requirements, compliance, et cetera.
And also very importantly, you want to tell the story, the success story, right? Go ahead.
Yeah, absolutely. So in the early stages, you want to make sure, not just metrics alone. You want stories, patient experiences, provider feedback, community trust. This really shows impact sooner, rather than the quantitative, though that is important. So those lived experiences really help drive adoption as well as the buy-in. Data still matters, but it needs to be tailored. Funders, communities, and leadership all need different information. So the more you can say with your information, the better. So as programs stabilize, metrics become more robust, but try to capture those stories up front early. And these are what often justify continued staffing and funding early on.
Yep. Let me give an example of that. Private funders and organizations, they have to do yearly reports usually where they send it out to their, say, think like I'm going to use United Healthcare Foundation. They have to send out a yearly report. By collecting those stories and sharing them back with them, they're able to put those stories and report that to their powers that be and their shareholders and their things like that. So you're also helping them complete the tasks that they have to do annually as well.
Yeah, very good. I think we addressed a lot of questions. Again, we can stay beyond the top of the hour if people are still hanging around. In summary, what we'll give you here is a 7-step program to bring telehealth to your community, kind of summarizing what we talked about. Not going to go into great detail, but it's a nice cheat sheet for you to consume. Also, some links here with some resources from the Mid-Atlantic Telehealth Resource Center that includes West Virginia, and then also the Center for Connected Telehealth Policy. I've written a number of articles on rural health and telehealth as well that may be of interest. And yeah, and then with that, again, take down the email here. Feel free to reach out to us with any questions you may have. We're happy to point you to the right resources and to make sure that you can maybe talk your ideas through with us and see what you would need. And with that, I think I'll just, yeah, I'll just hand it back to Annie or Emma. Emma.
Thank you so much. Can you unshare so I can share mine back?
Absolutely.
Thank you. And thank you so much to our speakers. That was y'all did great, and it was a lot of great information, so I really appreciate it. Does anybody have any questions for me, Annie, or the speakers in general that they would like? Okay. So just a few save the dates. My next webinar will be March 23rd at 1 p.m. It's going to highlight our North Star partners across the state. And if you're not familiar with North Star, it's a digital literacy program. And we're going to be highlighting partners and what they are doing and how their program is going. And then we have our West Virginia Connected Communities Network meeting tomorrow. It'll be the first one, and that will be taking the place of our Digital Equity Steering Committee meetings. And then we also have our Generation West Virginia Pathways to Progress Conference, May 14th, that you can register for using that QR code. And other than that, you can be in touch with me and Annie. Those are our emails. And thank you again to our speakers, and I hope you all have a good rest of your day.
All right. Thanks,
Thanks,
everybody.
everybody.
Thank you, everyone. Take care.